بسم الله الرحمن الرحيم. معانا النهاردة درس ال Problem Based Learning related to the topic of antepartum hemorrhage. Case 1, you are asked to review a primary gravida who has presented with vaginal bleeding at 39 weeks, 5 days gestation. She noticed this evening a small gush of blood and scabbard parietal stain in her underclothes. She denies actual abdominal pain but reports some intermittent lower abdominal discomfort. The baby has been moving normally during the day. So the patient is primary gravida, full term, small gush of small amount of blood, no definite abdominal pain apart from mild lower abdominal discomfort, and the baby is okay. On examination, the patient is warm, well perfused, hemodynamically stable, and represent increase in her blood pressure. The blood pressure is increased 158/100 with normal heart rate. The fundal level is 36 centimeter and the fetus cephalic. Moderate uterine tenderness is noticed. So we have two important signs that may help us to reach a very close one of the differential diagnosis. The patient is hypertensive and the patient has tenderness over her uterus. Patients hypertensive, we said that hypertension is present in 1/3 of cases of accidental hemorrhage or placental abruption. And the uterine tenderness pain is almost always present in all cases of placental abruption. The uterus is soft, but during palpation, 2 moderate uterine contractions are noted, so the patient may show or may have prodroma of labor. Speculum examination, cervical os closed, and there is moderate amount of vaginal bleeding. So the case is antepartum hemorrhage, most probably accidental hemorrhage or abruptio placenta for differential diagnosis. What are other causes could be responsible for this case? In addition to these other obstetric causes, expulsion of bloody show. This is very important. 2 uterine contractions were felt during abdominal examination of this patient. The patient is full term. Placenta previa is another differential diagnosis. In addition to other gynecological and general causes of bleeding mentioned before. Okay, fetal causes including vasa previa. What issue in the given scenario support your diagnosis? The issue in the given scenario support diagnosis is from the history the patient has bleeding of bright red in color, small amount of blood, and by examination the patient was found to have mild abdominal tenderness and the patient is hypertensive. This is the most important conclusive issue in the history and the examination, that the patient is hypertensive. This is very important. Elevation of the blood pressure during its measurement, in addition to uterine tenderness and history of fresh bleeding. What clinical examination would you perform and why? We are going to complete the vital examination for this patient if there are signs of anemia or not. And then we will perform abdominal examination. Full obstetric examination will be done to detect tonicity of the uterus, hypertonicity of the uterus. Observe the fundal level if it is rising or not. That may denote ongoing intrauterine condition. Auscultate for the fetal heart rate. Speculum examination should be done to exclude local causes of gynecological bleeding, should be done as well, and we will not do per vaginal examination until we do ultrasound to exclude placenta previa. Please, this is very important. The mark of the examination, of item of examination in this case, will be put on this situation, that you will not do a per vaginal examination unless you exclude by ultrasound that this case is not a placenta previa. What investigations would be most helpful and why? You should start by ultrasound. I'm going to do a good obstetric ultrasound to identify the position of the placenta, if it is placenta previa or abruptio placentae of a normal separation of a normally implanted placenta, in addition to confirmation of the gestational age, performing fetal viability, amniotic fluid index, and the biophysical profile, and definitely detect the presence or absence of retroplacental hematoma. This is very important, the most important investigation that should be done first. In addition, assessment of the general condition of the patient, complete blood count should be done to diagnose anemia, detect the general condition of the patient, if there is element of HELLP syndrome or any abnormality. In addition to ABO and RH typing and blood preservation, we should preserve blood for this patient during performing the blood sample for investigation. Perform liver function test for condition of liver enzymes to be normal, to exclude HELLP, here from thrombocytopenia, here from elevated liver enzymes. Kidney function as well, to confirm the condition is not complicated or not, and if we are in need to give magnesium sulfate if there is any obstacle or not. One of the parameters for following or follow up during administration of magnesium sulfate is urine output. If there is oliguria, we stop magnesium sulfate. So we should do kidney function test as well. Urine analysis for possibility of proteinuria to complete the picture, and CTG to assess fetal well-being. If you will, to classify the investigation, ultrasound to confirm diagnosis, the most important one. It should be done to confirm diagnosis. And then assessment the general condition of the patient, of the mother, maternal general condition. And then fetal well-being by performing CTG examination, cardiotocographic examination. What treatment options are appropriate for this patient? Actually, the patient is 39 weeks old, so the patient is full term, and the patient has uterine contraction. So this patient should be hospitalized and terminated. So the first one is hospitalization for this patient. Stabilization of already the patient is vitally stable. After performing her investigation, we are gonna to start insertion of wide bore cannula and urinary catheter. The patient is hypertensive, performing all investigation necessary for her, as we mentioned before. All investigation will be done, and then close monitoring or control of her blood pressure and other vital signs should be done, and observation of the fetal condition. My patient is full term, above 37 weeks, and the patient has active bleeding in spite of being mild, together with uterine contraction. So this patient will be terminated by cesarean section or vaginal delivery according to the obstetric indication. So we admit our patient, we do resuscitation, control of her blood pressure situation, send full labs, and then take a decision of termination when the labs are available, because it is not critical, the patient is vitally stable, just to control her blood pressure, and continue her investigation to diagnose if there is underlying preeclampsia, if there is underlying any systemic complications, and then we are going to terminate our patient by cesarean section or vaginal delivery according to the obstetrical indication. The second case, 37 years old patient, 5th gravid par 4, patient pregnant at 32 weeks, so the patient's preterm. Complains of significant prior-treat vaginal bleeding. She denies uterine contraction, leakage of fluid, or trauma. So no history of trauma, preterm patient, vaginal bleeding. Patient states that 4 weeks ago, she experienced some vaginal spotting after engaging in sexual intercourse. So it is some sort recurrent, and the previous one was due to sexual intercourse. As regards her obstetric history, she was delivered by cesarean section. The patient has history of 2 cesarean section before. On examination, her blood pressure was 110/60, normotensive, 80 beats per minute heart rate, normal temperature, heart lung examination normal, abdomen soft, uterus not tender, fetal heart rate 140 or up to 150 beats per minute, normal. What is your most probable diagnosis? This is a case of antepartum hemorrhage, most probably placenta previa for differential diagnosis. A case of antepartum hemorrhage, most probably placenta previa, and other differential diagnosis includes antepartum hemorrhage, rupture, expulsion of bloody fetal source as vasa previa, other gynecological cause, and other general cause. You should discuss all other differential diagnoses, but the most probable diagnosis is placenta previa. What issues in the given scenario support your diagnosis? The issue in the given scenario includes this bleeding is recurrent, first attack now, and the first attack was since 4 weeks following intercourse. It is painless, there is no associated pain. Causeless, this time is not, there is no a cause, but 4 weeks ago it was initiated by intercourse. Abdomen soft and uterus is not tender. This from the history. What are the risk factors in the given scenario support your diagnosis? My patient at risk of having placenta previa, abnormally implanted placenta, being of increased maternal age above 35 years old, and of increasing parity together with previous cesarean section. So she has 3 risk factors that make her more prone to develop abnormally implanted placenta, of advancing maternal age, and multiparity together with previous cesarean section. What clinical examination would you perform and why? Here the general examination, if there are anemia, if there is any mass detected elsewhere, if there is any abnormalities during the general examination. Abdominal examination to assess the confirm that there is no increased tone in the uterus, the fundal level is proportional to the duration of gestation, perform a full Leopold maneuvers if there are malpresentations or not, and auscultate the fetal heart rate. And perform a usual abdominal and obstetrical examination. Speculum examination should be done to exclude any cervical polyp, ulcer, or local cause of bleeding, and then BV should not be done because it may initiate severe attack of vaginal bleeding. Don't do bare vaginal examination in any case with antepartum hemorrhage for possibility of placenta previa. What investigation would be most helpful and why? As we mentioned in the previous case. Number 1, ultrasound, transvaginal ultrasound or abdominal with or without transvaginal is the gold standard and diagnosis in all cases of antepartum hemorrhage to exclude and confirm your diagnosis if there is abnormally implanted placenta, if there is placental separation, if there is retroplacental hematoma, in addition to the other data obtained by the obstetric ultrasound, من fetal biometry, من estimated fetal weight, من by physical profile, من Doppler examination, من amniotic fluid index, other usual measures done. Okay, and then we perform a complete blood count to assess the general, as we mentioned in the previous case. Okay, this investigation to confirm the maternal well-being and the fetal well-being by CTG cardiotocography together with abdominal ultrasound. Performing this abdominal ultrasound found that the placenta is related to the internal os, partially cover the internal os in this way. So this is partial placenta previa or major placenta previa because the placenta cover the internal os, most of the internal os. What are the maternal and fetal risk in such conditions? Complication of placenta previa. The patient can experience severe antepartum hemorrhage, pass into hypovolemic shock, and may be complicated by disseminated intravascular coagulopathy or DIC. Any patient suffer from antepartum hemorrhage from anemia, from exhaustion of the myometrium, hypooxygenation of the myometrium. The patient carries high grade risk of developing atonic postpartum hemorrhage. Also, these patients, sometimes this atony cannot be overcome by the different ecbolics used, and so we may be in need for life-saving caesarean hysterectomy. The patient has previous to cesarean section, so she has a special risk of abnormally invasive placenta, which may necessitate the loss of more blood, the need for more blood transfusion, and may result or end in cesarean hysterectomy with high risk of morbidity and mortality, especially if the condition was not planned for. These are the maternal complications. Fetal complications increase the risk of perinatal morbidity and mortality. Prematurity, my patient is 32 weeks gestation, so prematurity is there, IUGR is there, and massive blood loss that could compromise the intrauterine fetal life. What treatment options are appropriate for such case? My patient's preterm, 32 weeks gestation. The patient is vitally stable, mild attack of bleeding. And so in this way, I'm going to choose the conservative management. And so hospitalization, resuscitation of my patient, blood reservation, do the full labs and the investigation to confirm the condition, correct the anemia if it is there, correct any abnormalities if it is there, prescribe and advise the patient for bed rest, close observation of the mother by daily assessment of her blood pressure and general condition, evaluation of the fetal well-being regularly daily as well by physical profile and CTG. If the patient is Rh negative, give her anti-D immunoglobulin. Once you do conservative management, the patient should, even you will not do conservative management, any antepartum hemorrhage patient with Rh negative should receive anti-D if you are going to leave her for some time. If you're going to terminate immediately on the same day, okay, don't give her anti-D immunoglobulin. These patients preterm, and so we are going to give her corticosteroid to enhance fetal lung maturity. So my patient is preterm, less than 37 weeks, with mild bleeding, with good general condition of the mother and the fetus, and so we choose conservative management with hospitalization, bed rest, full assessment of the maternal condition, correction of anemia, blood reservation, anti-D in cases of Rh negative mother, daily fetal well-being observation by CTG and possible ultrasound every other day, and corticosteroid should be given to enhance fetal lung maturity. Okay, thank you. Bye.